Hello, I'm Dr. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, and editor-in-chief of the Journal of Clinical and Aesthetic Dermatology, affectionately referred to as the Green Journal, the JCAD. And I'm here to discuss issue highlights for the 2026 issue of the journal. So it opens up with a resident's corner where Daniel Butler, who is from Tucson, he's on faculty there. He's the assistant dean of student affairs, and he's in dermatology in Tucson. And he talked about pearls of wisdom from geriatric dermatology. And I understand that because I already have my Medicare card, had it for a while. So geriatric dermatology is dear to my heart. But, Daniel's a great guy. He's very interested in education. And he makes a very interesting point that there's a lot of discussion about anti-aging in dermatology, but a lot of our wisdom comes from people that have put in some time and put in some years, and that he basically grew up around four grandparents. So his life from early on was was very much involved with wisdom from older individuals. And he brings up some really interesting points about we have a lot more older patients coming into our offices and some of the adjustments that it's important for us to make. So, just a few highlights from this. It really is, I think, good practical guidance. Some of the changes that occur in aging skin, things that are related to the skin barrier, difficulty retaining moisture, more fragility, and what we call dermatoporosis, similar to osteoporosis of the bones. The skin has the same type of changes within the skin. And some of those factors we have to consider in terms of skincare, but also the fact that itching is present in almost a third of individuals that come in without a primary skin condition, but they're complaining of itchy skin. It's very common in the geriatric population. So is it somewhat innate to that situation in that individual, or do they have an underlying systemic condition that's causing that you want to evaluate and find out about? He also talks about the importance of balancing the care for different conditions and really looking at what is bothering the patients, depending on if they're very, very active or if they're wheelchair bound and never getting outside, and some of the needs that they might have, and also the accessibility in your office. A lot of these people take more time to get back into the room, to get in and out of the chair, to be able to move around, to be evaluated. So if you know that, it's important that your staff be educated on how to deal with that, because not all the patients are the same in that regard. And so the patients feel that that is understood about their situation and their family members that are with them. Also offering teledermatology options, because a lot of these people have difficulty with travel and being able to get in. So there may be times when in between it can be just checked in over the computer, not necessarily having to come in live every time. Now, a lot of the older individuals are not necessarily tech savvy, but they typically have a member or someone that's helping them with their care that can assist with that. So he goes over a variety of different suggestions in that regard. And they're things that you just might forget about. And it provides a checklist to remember these different issues, right? The next article that I want to talk about is a very important one. And the lead author is Diego de Ruiz de Silva. And going along with the theme of geriatric dermatology, I am the senior author on that paper, and several people contributed to this. It's on venous thromboembolism risk in patients with atopic dermatitis treated with abrocitinib, which is a Janus kinase inhibitor that has some dominance of inhibiting Janus kinase 1. And it talks about specifically female patients that are on both oral contraceptives and use nicotine, typically talking about smoking. Both of those independently are risk factors in and of themselves for thromboembolism. Now you're having a patient being treated with a Janus kinase inhibitor, which carries that as one of the box warnings, the potential for venous thromboembolism. So, what do you do in a patient that is on oral contraceptives and also smoking? So this was a drill down publication on the patients that were in the abrocitinib trials, and they also make some reference to the upadacitinib trials, but we didn't have all the data on that particular collection of patients in the phase 2 and phase 3 trials. And looking at those those categories of patients, it was uncommon that female patients had a venous thromboembolism, but typically it was patients that were very overweight and were immobilized, which is very, very common, both of those as risk factors for venous thromboembolism. None of the women that were on oral contraceptives and were smoking with their smoking history developed venous thromboembolism in the trials. Does that mean it's absolutely not possible? No, that doesn't say that, but it does give us a sense that that didn't stand out as, hey, really be careful, maybe not even consider utilizing this therapy or a Janus kinase inhibitor in this particular population. So I think it was a very important start, and I'm appreciative of that article. Another article is on prurigo nodularis and the pain cascade. Prurigo nodularis is making front page news because we have advances not only in therapies that are FDA approved and newer therapies that are coming along or may be effective off label, but also a lot of new data on the pathophysiology. And the difference between prurigo nodularis lesions, which are focal lesions, and a more diffuse itching that you might see with an eczematous dermatitis, a rash per se, is that there's a pain, a deep sensation, a discomfort associated with prurigo lesions that has to do with neural sensitization and pathways that involve the cutaneous nerves interacting with the central nervous system and the spinal cord. We still don't understand it completely, but if you are interested in prurigo nodularis, this article by Joshua Burstein, Aaron Burstein, and Todd Schlesinger goes through the information that we understand to date, also looks at the therapies, and it helps bring us to where we are right now in our understanding of this moving target. The next paper is a phenomenal paper. And this is written by Beth Childs and Joseph Marola from University of Texas Southwestern. Joe Marola is the chair there. He is a board certified dermatologist, rheumatologist, and one of the nicest guys you'd ever want to meet. A heck of a lot nicer than Jim Del Rosso, I have to say. And this is an article on what's new in cutaneous lupus erythematosus, guidelines, biologics, and beyond. There have been a lot of advances in understanding both systemic lupus and cutaneous lupus. And this article brings us up to date on looking at going back in how we categorize these lesions, focusing on just cutaneous lupus, for example, like so-called discoid lupus, versus some of the other manifestations, even acute systemic lupus, how it's different, goes through the classical differentiation of how we used to look at that. What I learned back in my residency in the 80s and did for years brings it up to date with what we understand right now based on having more information on the pathophysiology and the interplay of different cytokines and mediators that are operative that are now targets for newer advances in therapy. So this article gives you some excellent graphics, gives you a background, sort of an algorithmic depiction of how you walk through cutaneous lupus erythematosus and break it through different categories to differentiate. You didn't document it, it didn't happen. It's different now. Now the lawyers are saying if it's documented, it likely didn't happen because people are checking off boxes of templates when they're in the office to get through very quickly that may or may not have applied to the patient that's in front of them. And there's volumes of pages that a lot of this is not necessarily being looked at line by line. And that opens up for a lot of questioning. I've been in this situation in a deposition where they wanted me to talk about an office visit where I saw a patient, and it happened to be a patient that was suing another doctor, and they wanted to know what happened in my office visit. And it was a line by line drill down that a lot of it was checkoff boxes that wasn't necessarily something that definitely happened. And they're grilling you on the record on something that can be used in court, just like you're in the courtroom. It's it's part of the case that they're questioning you on what does this mean? What does that exactly say? So it's a different era, and we have to be aware that when we sign off on that chart, we're responsible for everything that's in it ultimately, not necessarily the person that did the documentation, but the clinician that's responsible for that record. They go through several other. Clay I shouldn't say they, Dr. Cockrell wrote this article just himself as a sole author. But the idea now that a lot of us are working for companies, a lot of these different venture capital companies or hospital systems or corporations are buying practices, and you're now signing a contract with that entity. You're not joining someone that you know that you're sitting down with and go to dinner with or discuss things directly. There are a lot of nuances in those contracts that you could be held to that if you don't pay attention to can come back and snake bite you later in terms of why didn't you do this or why wasn't certain information available to you? And you need to know what those things are. It's very, very important. It's the modern world. Practices are being bought up, they're being sold, and you're working for an entity that has a team of lawyers putting that contract together where you're trying to look at it yourself. Make sure you get legal advice. This is a great article. It's not to scare anybody. It's to really just bring to your attention how to be more aware and to preemptively handle a lot of these situations so you're not caught in the wrong crossfire. The next article by Aaron Chang, Ambry Kaleshi, Andrew Kosa, and the inimitable David Cotter here from Las Vegas, a good friend of mine and a great dermatologist. It's on clinical management of dupilumab-related conjunctivitis, erythema, and arthralgia in atopic dermatitis. Evidence from two cases that were treated with nemolizumab. So let me point out first, this is not a club of people getting together that want to pick on dupilumab. Dupilumab's been around a lot longer than any of these newer approved therapies by the FDA for atopic dermatitis, including the biologics. So countless more people have been exposed to dupilumab. So there are some things that come along that we recognize with time, and some of these have actually been added to the package insert after the drug was approved based on the pharmacosurveillance that happens in the real world. And there's more talk about the erythema, the facial erythema, arthralgias, and we certainly know about the possibility of ocular surface disease, conjunctivitis, with dupilumab and even some of the other biologics. Nemolizumab is an anti-IL-31 agent. So it's not anti-IL-4, IL-13 like dupilumab, and it's not anti-IL-13 directly like tralokinumab and lebrikizumab. So it operates in a different playing field. It's effective for prurigo nodularis and atopic dermatitis. And these two cases bring to light patients that had difficulty with dupilumab, that when they were switched to nemolizumab, their atopic dermatitis was controlled, but they no longer had those complications of conjunctivitis, facial erythema, arthralgia, and there are some excellent photographs. The point is, we have options that go in all different directions when we have what David Cotter has called, we did a presentation together for the Nevada Society with another dermatologist back in the fall, eczema treatment gone bad. It doesn't always follow the playbook. There are some cases that fall out of that bell curve. And we have many different options that we don't necessarily know. We might intuitively think, I don't think this is going to work based on the mechanism of action in our head theoretically, but it turns out they do. So it's important to recognize we do have places to offer patients if they end up having a problem. Chronic disease is very frustrating. It's nice to know, like you're on the yellow brick road and the scarecrow is going, you can go this way or that way. It's nice to know there's not only one way to go on the yellow brick road. Hopefully, all the audience knows what I'm talking about with the Wizard of Oz, right? That is a little bit time dated, right? So the couple of other articles, just to point out that they're there. I certainly want to bring this to a close, but there was a great article by Dawn Merritt and others with Todd Schlesinger, who does a lot on actinic keratosis and skin cancer as the senior author, seasonal and geographic trends in photodynamic therapy and cryosurgery use in the United States. And they looked at a cross-sectional study from 2015 to 2022, and they basically found that photodynamic therapy, it's more involved, it's more time consuming, there's more downtime, is going to be performed more in the cooler months overall, if you look at across the board, where cryo surgery for liquid nitrogen doesn't matter if it's the heat of the summer, the cold of the winter, or anywhere in between. So there are seasonal differences in actinic keratosis treatment. We would expect it. It goes through what some of the clinical implications of that may be as a clinician for how you preemptively time things, because this is not a one shot, it's over condition. That damage to the skin, patients will develop lesions over time, and you certainly want to stay ahead of it because they are forerunners of skin cancer. They're a marker and a precursor of skin cancer, primarily squamous cell carcinoma, but they also are telling you the patient's at risk due to the photo damage for basal cell carcinoma and melanoma. The final two articles I do want to mention, intramuscular triamcinolone, IM Kenalog, in quotes, that has been around for years for acute treatment of patients that come in with eczematous disorders of a variety of different situations where they get an intramuscular injection and they get pretty quick control of their itching and of their disease state in many cases. But there's been a lot of controversy because it's a systemic corticosteroid. It has a depot and it can actually be influencing the patient systemically in terms of their adrenal axis and their inherent cortisone production on their own that can have some implications that may be adverse effects. Well, these are two clinicians, Dr. Douglas Robbins and Dr. Vivek Vemagunta, right? And actually, Vivek Vemagunta is not a physician yet, but was very helpful to Dr. Robbins in putting the article together, where they go back through what intramuscular triamcinolone can do for you favorably. So they're taking, in a debate, they're taking the other side of it and going through that particular information because it is important to see both sides of the equation. And then the final article, you may or may not be familiar with adaptogens. Adaptogens are found in plants. So if you think about it, if you're outside and it's a hot day and there's a ton of sun exposure and now it starts raining or it's windy, you could go inside. You can protect yourself from the environmental stressors. Plants cannot. If the plant lives in the forest or in your backyard, it has to accept what it gets thrown at it all the time. It can't run and protect itself. So some very smart people figured out that there are likely some extracts in plants that are adaptogens because they can adapt to these different stresses that are occurring in the environment. Things like oxidative stress, temperature, changes in the environment, on and on and on, identifying what some of these components are, and then formulating them to see if they provide the same adaptability or some form of adaptability in human skin that now helps human skin protect itself the way a plant would protect itself. Seems elementary, but it's absolutely brilliant. And this article goes through a double-blind, split-face a trial evaluating a particular serum that contains plant adaptogens versus a moisturizing lotion, both pre and post fractional laser in patients with mild to moderate photo damage. So it's an example of one product. They go through different adaptogens, but I think it's important to think about the concept. We're not just throwing around a marketing term because it sounds cool, and patients are going to say, "Oh, are you using that product with an adaptogen?" I am, you know, when they're at their club, the country club or whatever, there's scientific reasons behind it, and you could determine yourself what you believe the validity of that is. One final message that I'm very happy that the people I work with at the Journal of Clinical and Aesthetic Dermatology at Matrix Medical, we're all on board. We have four new associate editors that I have approached and asked to participate on the JCAD. You'll be hearing more about it. They're going to be helpful in terms of bringing articles forward, reviewing articles, bringing forth different projects that I'll be working with directly. And they are Graham Lichman, who practices here in Las Vegas, a great guy. I work a lot with him. David Cotter, also who practices here in Las Vegas. And we're not in the same practices, but it goes to show you you can be collegial even though the practice down the block may be thought of as competitive. As dermatologists, we're in this together. We also have Diego Ruiz de Silva, who is from Virginia, a great dermatologist. And we have a nurse practitioner from Arizona, a brilliant guy, David Sider. So all four of these you'll be seeing an announcement. It'll be forthcoming, are going to be more and more involved. We're always trying to bring the JCAD not only one bar up, several bars higher with every move we make. Thank you very much. And I look forward to hopefully seeing you at a meeting or next month when we do highlights for February 2026. Thank you.